Why would that be important for, like, you know, the community to know what's coming down the pipeline? Okay. Then let me know. If you can, let me know when you're in Atlanta or when you're in DC. Can you go to DC or something? Where you live in Atlanta? Where you live? Where you live?
Morning. Good. I did. I said earlier.
Well, you can also get
Head up, eyes open.
and they take very good care of you.
Yeah.
It's like, so
I'm staying with you.
no, not the ones downtown.
I'm in
Midtown. Yeah. Right. Yeah, I would always stay there. I would always stay there when I wanted to. Yeah, I'm all like, oh, right. All right. Well, holler before you leave. I'm going to take the shuttle 3. Okay.
I'm just one of his many mentees.
Yes, sir. I was from the representatives that when I was in massage therapy school, one of the exercises we had was the shooting thing. And up to something that was you're supposed to look in that person's eyes the whole time you do it. And it was amazing to me how the first 10 people was just weird, and the next 10 people was cool. And by the time you got to the third 10 people, it was like, yeah! and then, because there were 120 of us, we didn't get to everybody. I was feeling
Joe Balance. I've worked with you for many, many years.
next batch of
Pleasure to be here.
it's a blessing. Ready, back the hand. What can they say? Blessing and what do I see? What we get always questions. Stuff, all that good stuff. Thank you, sir. Yes, sir.
Yes, I was just bragging about it. I learned.
She works hard at opening the business. That's hard. That's hard. It's not because she was not put work. I usually get the right information, the right heads up. The issue is, I look at it, read it, and see it in time. What you like about the talking about? Step back and simulation. Information and what I needed to know. Joe Biden. Yeah.
we standing? We need to be up on stage. What do you want us to do?
No, we're not going to be on stage. We're going to be right here. Right here.
You want?
One more.
Now back up to get the shoes. I don't. She didn't wear those shoes for fun. Thank you.
Tell me what you think.
Oh, I'm sorry. You know you will. Is that all right? No.
No, with my hair was here.
And you're also, you're under the slide, so
Where do you want us to stand?
if we go to the edge, that way the light's not overhead. Spotlight's right there.
This is button or unbutton?
First button is
He's been trying to get his level. I'm not there.
That's what I see. I put something else.
Better. You guys need to know. Mariah runs the play. She's on the presidency.
Because that's where you got the slide deck for me. Okay.
We had a great conversation yesterday.
So after lunch,
Evidence-based.
or just during lunch, what? When we'll do the session. What you
After
do
lunch.
after lunch.
So you
Okay.
do the invitation now.
Okay.
And just a reminder, President of the engineer is out on sick leave, so you may want to mention something about her prayer for her to recover.
Is it McNair or McNair?
Ask Dr. Carter. Because I don't want to, I be messing people's name up. I don't want to be wrong.
Who did you tell me to ask?
What I do? Oh, wonderful. Oh, goodness gracious. I'm glad you're here. Oh, wow.
That'd be very much.
Good morning. We'd like to ask everyone to take your seats at this moment, please, so we can get started. Good morning. My name is Daphina Ward, and I have the honor of serving as Interim Executive Director with the Southern AIDS Coalition. And on behalf of SAC and all of our partners, especially our friends here at Tuskegee University, and our very generous and supportive sponsors, we want to thank you all for coming and being here with us this morning on hallowed ground. Tuskegee University is a very special place, and upon our arrival the other day, as we were working and preparing for you all, we heard countless times that this place has spirit, and that it does. And we are just so honored to be here in this place with you all this morning. Before we begin, I know a number of you joined us for the prayer breakfast at St. Andrews this morning, and y'all, we prayed this morning. Did we have church this morning? Yes, we did. And so in the spirit of the way that we began our day early this morning, we're going to continue now with an invocation. With an invocation by Reverend Edwin C. Sanders II, who serves as senior servant at Metropolitan Interdenominational Church in Nashville, Tennessee. And we welcome our friends who are joining us online via Facebook Live to join in prayer with us for this day. And we look forward to having those of you who are here in the room and those of you who are joining us virtually to share in this special day with us. Reverend Sanders.
Good morning. What a beautiful and glorious day God has given us to come together to share in this time and this experience, a time to grow, a time to develop new levels of awareness, appreciation, understanding, and insight as relates to these issues that are before us, as relate to the whole question of how we effectively address HIV and AIDS. The theme of lifting the veil is one that is of profound, I think, significance for us all. For indeed, there's a way in which, over and over again, there have been those moments in our journey in this experience called America of how it is that the veil has been lifted. When you come onto this campus and you find yourself staring upon the very powerful statue that is evidence of how indeed a single person with a vision that was clear, a vision that was one that went so far beyond the time and the moment when indeed this institution was established, and how indeed the intent was that there was a veil that needed to be lifted. Over time, if you chase our history and trace our history in terms of an experience as a people, there's a way in which we know along the way there have been moments when clearly, distinctly, specifically, the veil has had to be lifted. So I want to ask you just for a moment to do two things with me. And as we prepare to pray, I've brought with me for this occasion a litany that I'm going to ask you to join in reading along with me. And this litany is one that has been a part of the life of the congregation that I serve for 39 years. When we had our first worship service on February the 1st, 1981, we read this litany, and I think it has meaning for us as we find ourselves focusing on trying to understand how it is that we see the face of God in all that we do in this work that is before us. The title of the litany is The City, and I invite you to read along responsibly. O God, the city, for people to live and to know one another. O God, who was laid off last week and can't pay the rent nor feed the kids.
Help us to be with you.
O God, who hangs on street corners, who tastes the grace of cheap wine and the sting of the needle.
Help us to touch you.
O God, who is pregnant without partner, who is child without parent, and who has no place to play.
Help us to know you.
O God, who can't read nor write, who is on welfare, and who is treated like garbage.
Help us to know you.
O God, who lives and no one knows their name, and who thinks that they are nobody.
Help us to know you.
O God, who is cold in the slums of winter, and whose playmates are rats.
Help us to touch you.
O God, who is chased by the cops, who sits in jail for 7 months with no charges brought, waiting for the grand jury and no money for bail.
Help us to know you.
O God, who is old and lives on $40 a month in one crummy room and can't go outside.
Help us to know you.
O God, who lives in the projects of federal, state, and city indifference.
Help us to see you.
O God, who is 15 and in the 6th grade.
Help us to touch you.
O God, who works all day, who feeds and cares for her children at night and dreams of better days and is alone.
Help us to know you.
O God, whose toys are broken bottles, tin cans, whose play yard is garbage and debris, and whose house is the floors of the condemned buildings.
Help us to touch you.
O God, who holds tight to the hem of her mother's dress, whose eyes are empty, whose tears are large, and whose face is dirty.
Help us to touch you.
O God, who is HIV positive and consumed by fear.
Help us to touch you.
O God, who is uneducated, unskilled, unwanted, and unemployed.
Help us to know you.
O God, who is all people.
Help us to love you.
Let us pray. O good and gracious God, truly, we seek at this moment to know you in ways that too often end up being overlooked, unappreciated, and not fully understood by those who walk this plane called earth with us, and too often have ways in which their judgments, their assessments, their evaluations, their ways of looking at, their ways of seeing the ugly reality of fragmentation and division that too often exists between us. We ask you right now to help us to see each other as you see us. Help us to look beyond the superficial. Help us to look beyond the things that really are no more than that which is on the surface. But we know that at the center, at the heart, at the core of all of our existence is that which represents the thread which binds us together and helps us to appreciate how it is that we're able to do that which is truly exceedingly abundantly above all that we can ever ask for or imagine. So we ask you right now to touch this experience that we're having together in a way that there will be new windows of awareness opened in our hearts, that we will have new levels of discernment and gifts of awareness and understanding, that we indeed will end up being a people when we leave this place, will leave with a new sense of dedication, a new sense of commitment, a new sense of responsibility, a new sense of the need to personally be accountable and to hold those around us accountable who do this work in your name. We pray for all who have laid the foundation that allows us to come to a place like this, Tuskegee University, and be able to understand that there are spaces where there is work that is being done, where research is unfolding, and where people are engaged in creative endeavors that will allow us to have the responses that we need to have in order to address this disease effectively and meaningfully. We especially want to say thank you for the decades of gifted persons who you have sent to this institution in order to continue to allow the light to be cut on at a time when there are those who are trying to shut out the light and cause there to be a spirit of something that is less than we can truly appreciate in terms of who we are as a people. We thank you for Booker T. Washington, but we also thank you for Dr. McNair, who would be here with us if it were not for her dealing with our own health crisis at this very moment as we are here together. But we ask you to allow her to know that indeed the work that she does and the tradition in which she stands is something that we celebrate and appreciate. So allow us to feel your embrace, allow us to sense your presence, allow us to hear your word, and allow us to know in no uncertain terms that with you and through you, all things are possible. So in the name of God, even though that name might be one that we know differently, some might call you Allah, some might call you Jehovah, some might call you Jesus, some might call you Buddha. There are many names that people call you by, but we know that you're one God, that you're a God of justice, that you're a God of mercy, that you're a God of unconditional love, grace, and peace. And we pray that all of those qualities we will experience together as we share in this time, here, this day, and beyond. Ashe. Amen. Amen.
Thank you so much, Reverend Sanders. This work would not be possible. We would not be here on this illustrious campus if it were not for important partnerships and one that we hold in high esteem and have had the honor of working collaboratively with over the past few months in developing this program is that of Tuskegee University. And at this time, I'd like to invite up Dr. Tamara Floyd-Smith, who serves as Associate Provost and is an Assistant Professor in Chemical Engineering, to bring greetings on behalf of the university. Please welcome her.
Good morning. Good morning. As the MC stated, I'm Dr. Tamara Floyd-Smith, Associate Provost and Professor of Chemical Engineering here at Tuskegee University. On behalf of our President, Dr. Lily D. McNair, our Acting President, Dr. Ruby Perry, and our Interim Provost, Dr. Carla Jackson Bell, it is my privilege to welcome you to Tuskegee University. As the MC stated, Tuskegee is hallowed ground. Tuskegee is an enchanted place. The proper noun Tuskegee evokes many positive historical references, including, but not limited to, Booker T. Washington, founding principal and advisor to presidents. George Washington Carver, the genius scientist. The Tuskegee Airmen, heroic World War II bombers, and more. But the proper noun, Tuskegee, also evokes one darker historical reference, the Tuskegee Experiment. Yes, growing up in rural Alabama, I heard of the Tuskegee Experiment. Older relatives whispered about the Tuskegee Experiment and cautioned that you better try to help yourself before you go to the doctor. They were referred to as home remedies, those help yourself methods, and included various concerning ingredients like turpentine. Yes, I watched Miss Evers' Boys, but I didn't process the full gravity of the Tuskegee Experiment until I incorporated human subjects research into my own research portfolio. I had to complete the NIH, or National Institutes of Health, Human Subjects Training. It included the Tuskegee Experiment as a significant part of the training to illustrate one of a few ethical failures in human subjects research. Some define fail as first attempt in learning. If we apply that definition to the Tuskegee Experiment, it is only fitting that you convene today to discuss how to avoid a second failure when dealing with this new public health crisis, HIV, almost a century later. We are delighted that you took the time to attend HIV, Lifting the Veil, to strategize on developing solutions for the enduring medical mistrust resulting from the U.S. Public Health Service Syphilis Study. We hope you enjoy the rest of the program and receive the help requested during the litany. How many of you felt that in the litany? Help us, help us. Again, welcome to Tuskegee University. Thank you.
Thank you so much, Dr. Floyd-Smith. It is just truly an honor to be here. I don't know if you all are excited or feel the energy. I feel the energy. And I'm just so excited looking out at all of you, all of the brilliant folks who are in this room, and the fact that we know what our problems are. and the fact that we are here today to talk about solutions and acknowledging this is the beginning of our process and our work together. So Southern AIDS Coalition, we're an organization that is really focused on being a bridge in the South. We could not do our work without all of you. And folks who are in our communities throughout the region. And we acknowledge that and appreciate that and know that we will only turn the tide if we are truly engaged in this work together. And our work is in the areas of public health advocacy, and then also capacity building assistance and training for organizations, leadership development, education for folks who are living with and impacted by HIV in their communities, research evaluation, and strategic grant making. And we welcome you to talk with any of us about our work and opportunities where we may collaborate together. And we have a vision for a new South, a vision where everyone who is living with or impacted by HIV can have access to the care, the services that they need, that they can exist in communities that are not stigmatizing and judgmental. And we believe that we can create that if we all work in collaboration to do so. And I would be remiss, please turn your eyes to the screen to look at these beautiful people who we call the Southern AIDS Coalition team. And I would just invite those who are in the room to stand. Aquarius Gilmer, Marvin Anderson, and by extension, Keisha Hudson, who's here working with us out of Birmingham. We could not do this without one another and without all of you. And would also like to recognize one of our board members who's in the room, Ms. Bambi Gaddis, Dr. Bambi Gaddis, out of South Carolina. And I appreciate you so much for being here with us. And lastly, we know that these things can only happen when we have the resources, and I'm sure resources will be a big part of our conversation today, and the funds that are needed. So just have to thank our sponsors by name, and that would be Johnson & Johnson, NACHO, Merck, Avita Pharmacy, Black AIDS Institute, Tuskegee University, Gilead, and GLAD. So please give a hand to all of our sponsors who are doing this possible. I would like to welcome my colleague to the stage. We often call him the architect because he is always building a plan. And that is Aquarius Gilmer. He always has an idea. He is an alum of the illustrious Tuskegee University and brought us to this space for this. And we are so thrilled to be here.
Thank you, Daphina, and good morning, everybody. T-U. You. That's right. So I am Aquarius Gilmer. I am the Director of Government Affairs and Advocacy at the Southern AIDS Coalition, and I have the distinct pleasure and privilege of working all across the South toward the goals that Daphina just identified, and I am deeply privileged and honored to be in this space, on this sacred ground. I remember even driving up the other day, I became overwhelmed with memories of how I was really groomed on this campus and shaped on this campus. And Dr. Bambi Gaddis is also an alum of this institution. So we seek to do Tuskegee well in our excellence as we leave this place. And when the idea came to me to give birth to this, it was after the administration had released the Ending the HIV Epidemic, a plan for America. And we didn't rush to kind of do a response to the plan. We wanted to sort of take our step back and see what we could do, survey the land, to see what it is that we actually could do. And the first thing that we did was we launched an initiative called Southern Solutions, where we brought together every person that was identified in the plan in the South in one location to figure this stuff out together. Similarly, after that, we realized, in conversation with community members, with physicians, clinicians, cross-sectoral stakeholders, our pharma partners, that we also face not only the challenge of new partnerships and different partnerships, but we also face a challenge that seemingly was insurmountable, and that is medical mistrust and racism in public health. And I thought of no better place than to reignite the conversation than to do it here. And so that is why we're here today. This is not a one-time thing. I am hoping, it is my aspiration, that this is a 10 to 15-year initiative that will rotate across the South at HBCUs and MSIs to deepen the conversation, because we will not solve everything in one day and 3 hours. This is a big conversation, and we need all of us in this room, all of our friends who are joining us virtually. Thank you. We need you all. And then those who are not in this room, who are not even online, who we need to be engaged in this conversation. And so I hope that we would today join us and would, you know, as they would say, growing up, put your thinking caps on, and we're at Tuskegee, so I know we're thinking. And I would like to thank, there's a few people who have helped make this possible, and that is in the person of Sabrina Taylor. She was out there with our registration, so Sabrina Taylor is also a Tuskegee alum. Let's thank her for all of her hard work. Dr. Jasmine Ward, who's also an alum. Please stand, Dr. Jasmine Ward. She led all of our student engagement activities. And Dr. Vivian Carter, who will join me on the platform now, also was our campus liaison. And when I did not have all the words and the answers, she heard me out, caught the vision, and said, let's do it. And so I appreciate these black women, and I surround myself always by black women. So if you want to be successful, get people, black women around you who can support and amplify what you're trying to do, and who will groom you and get the laziness out of you. So, my first B- was her, and she told me I earned it. So, I would be remiss to say that we are deeply gratified to be here. This is going to be an interactive experience. We're not going to try to compete with your cell phones and your computers. We're actually going to ask you to engage us with those tools. And I'm going to let Dr. Carter also help to frame why we're here, what we're trying to do.
Well, let me just again say thank you to the Southern AIDS Coalition for bringing this to fruition. I mean, this is it has been a remarkable couple of days, but just in the conversations we had to bring this about, again, refreshed and renewed my drive. I'm always fighting, but here again, you refueled it. One of the things that Aquarius and I were discussing, and Jasmine and Sabrina, is that we needed to also think about mental health. Okay? Addressing that. I mean, we're good. It seems like we got the science, the natural science component down, but we still are wrestling with that behavioral health component. And so we want to interject that into this conversation. And yes, I am the chair of psychology and sociology. So of course. But the other thing is that it is important that we not forget the pivotal role that this study, the United States Public Health Study of Untreated Syphilis in the Negro Male, that this is a part of American history. And it is a pivotal point in American history. And we must not forget that. We must learn from it. And that's what we're here to do. To talk about every aspect. The social, the political, the economic, all of those factors that will feed into us addressing this issue of HIV. It's all interrelated. But we've got to come up with strategies. My father used to say, I'll listen to a man with a dream, but I'll follow a man with a plan. Thank you.
Thank you.
Thank you, Dr. Carter. Real briefly, we have some very important and special people to the Southern AIDS Coalition who are in the room. And that person of Jesse Miley, who's the CEO of AIDS United. Would you please stand, Jesse? I don't know if you're here. Thank you so much for your presence. Thank you so much. We also have our friends from the federal government who did not count it robbery to be with us today. So we thank you all. Would you all please stand? These are the folks who work every day in and day out on our behalf. So we thank you all for your service. Thank you, thank you, thank you. And at this time, I'm going to allow one more thank you, and that is to our, this morning we had a prayer breakfast where we actually prayed. More often than not, oh, thank you. More often than not, I told the panelists I've never been to a prayer breakfast and they actually prayed, beyond blessing the food. So this morning, we had a dynamic panel. I want to say thank you to the folks who are on this panel, Dr. Pam Foster, Dr. Ulysses Burley, Dr. Jagadisa Dacus, Minister Elder Kamarion Anderson, Reverend Edwin Sanders, and Deacon Darrell Rock. Thank you, thank you, thank you, thank you, thank you. That was a phenomenal conversation. It was powerful, it was rich. And so I appreciate you. And at this time, we're not going to delay any further because time is of the essence. And I understand that I was getting texts all throughout the night about the traveling challenges it took some of us to get to this place. And I think it's a really powerful reminder of where we are. And sometimes what it takes to get to a place like Tuskegee. But Dr. Carter reminded us yesterday, more importantly, what it takes for folks who are trying to get out of a place for better lives. So we are really privileged in that aspect, and I hope that we leave this place with a renewed sense of commitment to our work. So Dr. Carter will now introduce Dr. Warren, and then we will start off with our first webcast panel.
I'll just say, this individual has I could read his bio, but I won't because it's so long.
Right.
Dr. Reuben Warren is held in the highest esteem because of his tenacious spirit. And I can say that because I served up under him, so I know. We have had a long relationship that is rooted in deep respect for each other's commitment to this institution and what it stands for. Dr. Reuben Warren is the director of the Tuskegee National Center for Bioethics. He has taken that position and made that institution into a center for social justice. He has helped again to frame the correct version of the study. But I will let him come to you in his own way. But I want to introduce to you again the director of the Tuskegee University National Center for Bioethics, Dr. Reuben Warren.
Good morning. Good morning. Y'all seem a little bewildered when where you said TU. Some of you act like, what is he talking about? There's a mantra at this place. And it simply says, if you don't know about this place, you need to ask somebody. And so, even if you don't know, you're supposed to act like you know. And so when somebody says TU, you have to say, you know like you really know. Because when we started, you said, I was over there hollering. So we're going to try that again. It's important. TU. You know. TU. You know. TU. You know. That's better. And you ought to be inspired when you feel that. My name, as you heard, is Reuben Warren. I direct the National Center for Bioethics and Research in Healthcare here at Tuskegee. Welcome to this place, this spiritual place. And when you're on this campus, it is spiritual. I used to wander, I'm bringing everybody's child to come to Tuskegee. I used to wander and I would feel spiritually grounded. Then when I joined the faculty, it was every day. It was every day. For me, I'm honored to be here, and for me, racism is a part of history and the current ethos in this country. I know you feel it. In my view, racism is a power dynamic that is continuous and started in this country in 1619 with the transatlantic slave trade. the middle passage, and manifests itself today in painful, substantial, and measurable ways. You've heard about the story of Henrietta Lacks in the United States Public Health Service Syphilis Study. However, there are so many other instances of documented racist bigotry directed toward black people and other people of color. Yeah, you at Tuskegee, you can say what you feel. You don't have to hold back. We've heard the name J. Marion Sims. Have you? The father of gynecology, the father of gynecology. Well, in the late 19th, 20th century, Dr. Sims perfected his vestibular vaginal surgery on enslaved black women without anesthesia. Did you hear about that? Well, if you haven't, we just published a commentary that came out Wednesday night in the Journal of the National Medical Association. The title of the commentary, "In the Interest of Science or Humanity, Marion J. Sims was wrong then and now." Then and now. In the article, we argue that for the sake of science must be secondary to the sake of humanity. We end the article by the proposition that ethics must serve as the essence of guidance for our forward path. Ethics is undergirding all that we do. Tuskegee is well known around the world as a place of good. You've heard it. Tuskegee Institute, Booker T. Washington, George Washington Carver, the Tuskegee Airmen, the Tuskegee School of Nursing, the first in Alabama to offer the bachelor's degree in nursing. Y'all didn't know that? Wow. The first. All right. Our dean is here. And a blip called the Tuskegee Study of Untreated Syphilis in the Negro Male in Macon County, Alabama. A blip. Blip. So when you hear that blip, then you start talking about the things I just read. You may know it as the Tuskegee Syphilis Study, a misnomer. Well, it has been about 80 years since the study began, about 40 years since it was exposed, and 23 years since the president's apology at a White House ceremony. William Jefferson Clinton. The United States, he said, government did something that was wrong, deeply, profoundly, and morally wrong. All those things. That's what the president said. He apologized to the men who were in the study, to the African American community, and to the nation for an horrendous, unethical event that violated every principle of human subject research and healthcare delivery. I'm going to go quickly because it's not a keynote speech, but I got to say something. The event was the infamous Tuskegee Study of Untreated Syphilis in the Negro Male in Macon County from 1932 to 1970. The longest non-therapeutic study in U.S. history, the longest one. It was conducted not by Tuskegee, let's make it clear, but the federal government. And I take great pride in the federal government folks showing up, because they know we're going to say what we're going to say, and that's what we do. But things have changed with some of us that are in the government. Trust me, I'm working with them. Since that time, the so-called study has had many titles. In my view, the titles that have been used to disguise and to confuse what actually occurred and why. We called the so-called study was fully exposed. The men and their families felt anger, shame, and a profound sense of betrayal by the government and the doctors who they trusted. The original title, the U.S. Public Health, no, that wasn't the original title. The Tuskegee Study of Untreated Syphilis in the Negro Male in Macon County, Alabama, best describes transparently what happened. The issue, they use the name Tuskegee. What comes to mind? Tuskegee, honor, glory, pride, good work. Booker T. Washington, honor, pride, glory, good work. George Washington Carver, the Tuskegee Airmen, the Roosevelt Schools. Look at that. They plug Tuskegee in. So whatever happened, it was going to be good because it was Tuskegee. Think about it. I'm going to finish because I don't want to start to preach.
Well,
The government characterized the study in a certain way. I want to characterize it differently in a public health ethics context. Violations, withholding appropriate treatment, public health ethics violation, cultural insensitivity, incompetence, and inefficiency, public health ethics violation. Deception, they lie, public health ethics violation. Exploitation, abuse, public health ethics violation. And an apology, was it authentic? I'm not sure. I was there, but they did it anyway. HIV may be different from syphilis, pathologically, medically, scientifically, but the ethics challenges are quite similar. Use the lens of race, ethnicity, sex, gender, income, age, and geographical locale as you talk today. Put that lens on. Don't think that we all look the same, we all act the same, we all live the same place. It ain't true. Use a public health ethics lens as we have our conversation. And if you do, you won't get it confused. T-U?
You know.
Thank you. As we get into the substance of what we're going to talk about today, I want to call forth a second panelist. Let me get it so I can read it right. Rear Admiral Sylvia Trent Adams. She's in the house. Nurse Rosetta Roberts. She's in the house. Dr. Maureen Goodsmith. Did I say it right? She's not in the house. Dr. Eugene Aquarius. And Miss Joe Valentine. These are some of those government folk that I've learned to trust, and I don't trust me. So let's let the conversation begin. First panelist. Yes.
Good morning. Good morning. So, make sure we are technically ready to go here. It says Eugene's first.
Oh, okay. I'm fine. I just gotta get out of this chair.
You know, these older folks can't be sitting down in chairs that are too low.
Thank you.
So good morning, everybody, and I'm really honored to be here. For those of you, I'm from the Centers for Disease Control, and of course, we are in the midst of dealing with coronavirus, so I was lucky to be able to get out and come, but I'm glad this was really important to me. So in the brief time that I'm here today, I'm going to give you a snapshot of what the data tells us, describe some of the unique factors that are driving HIV in the South, and talk about how HIV and syphilis are connected, just briefly, and then sort of talk about some strategies we can use to combat HIV and other sexually transmitted infections. So what I want to do is first start with some of the data. So in 2018, there were about 39,000 new HIV diagnoses reported, 38,000, sorry, new HIV diagnoses reported in the United States. 1 in 5 of those diagnoses were among women, and black women really accounted for 60% of the diagnoses among women. Male-to-male sexual contact, or MSM, as written in the slide, accounts for nearly 70% of all the new HIV diagnoses, and 52% of HIV diagnoses were in the South. As I mentioned earlier, the South accounted for just over half of the diagnoses in the United States, and the South includes the 16 states that are sort of on the slide in the District of Columbia. So as you can see, in the South, 1 in 5 diagnoses were among women, and again, black women accounted for the majority of those diagnoses. 3 out of every 5 diagnoses were among black women. And men who have sex with men in the South accounted for 65% of the diagnoses. And among those diagnoses, 48% were black MSM, 25% were Hispanic Latino, and another 23% were white. And of course, 52% of new diagnoses in the South were among African American persons, black African American persons. So when you look at rural areas, like the rest of the country, the majority of HIV diagnoses are in urban areas, but however, when you look at the South, 24% of diagnoses in the South were in suburban or rural areas. So, this is one of the unique challenges that we're having to deal with when we talk about southern states. In order to really address this epidemic and end the epidemic, we've got to address where HIV is occurring and combat it in those areas. And if you know, being in a rural community presents a number of different challenges, including some of the things that I'll mention in a few minutes. In the South, an estimated 82,000 people have had HIV but don't know they have it. These are people who are actually living with HIV but don't know they have it. And so, and that's really important. So for us, HIV testing is really the gateway for people with HIV to get to prevention services and to treatment. So if you get an HIV test and you test positive, you really need to get into treatment as soon as possible. And if you test negative and you are a candidate for PrEP, a pre-exposure prophylaxis, or some other prevention intervention, it's really critical that you take advantage of those tools. So there are a number of reasons that I believe the heavy burden of HIV is occurring in the South, and there's some of the things that Dr. Warren mentioned earlier, and some of those are socioeconomic factors, things like income inequality, poverty, and homelessness or housing instability, some of those, and of course transportation. Because getting to and from the doctor, even in urban areas for some people in our community, is very challenging. But then there are other issues that I think are creating additional disparities, and these are not unique to the South, but they're more prominent in the South, and these are things like racism, homophobia, stigma, both internalized stigma as well as external stigma that comes from members of our own community as well as others. So these are all issues that we're going to have to address if we're going to be effective in eliminating HIV. Now let me talk briefly about HIV and syphilis co-infection. Like HIV, syphilis, primary and secondary syphilis cases are highly concentrated among men who have sex with men. In 2018, nearly 80% of all primary and secondary syphilis cases among men were among men who have sex with men. So that's really 80% of the cases. And when you look at those cases, a lot of those are people who are actually living with HIV. We know that having an STI, syphilis, like syphilis and rectal gonorrhea, etc., increases a person's risk of getting HIV. And a recent research study suggested that an estimated 10% of the new HIV infection among MSM are caused or caused by STIs. So effectively treating sexually transmitted infection, especially in men who have sex with men, is HIV prevention. So last year, the Georgetown O'Neill Institute had a special policy project where they brought in a bunch of people from communities, as well as academics, to talk about some of the challenges with addressing HIV and STI co-infection. And they released an issue brief that really talked about some of the things that could be done. And the next slide just highlights some of the work that's already being done and that could be enhanced to really address STI and HIV and STI integration, improve HIV and STI integration and coordination. There's categories under surveillance, and one of the things that we are currently doing and are really wrapping up is expanding our STI, strengthening STI surveillance and expanding our capacity to do cross-matching of our two systems. Because if a person is identified in, let's say, in an STI system, in the STI surveillance system, as having rectal gonorrhea or syphilis, and they are not HIV infected, that person is a perfect candidate for PrEP or one of the biomedical interventions. Similarly, under epi research, we do a number of epi studies, and we need to make sure in all those studies, when we're testing, when we're engaging and collecting data on HIV, we need to be collecting data on STIs as well as hepatitis to really document their level of co-infection. STI screening is actually an integral part of routine care for people who are with HIV. So every person, when they come in, at least annually who are living with HIV, at least annually need to be screened for STI. That's not happening. And in some cases, they need to have more frequent screening depending on how sexually active they are. But we need to make sure we're screening all persons with HIV at least annually for syphilis and for gonorrhea and doing 3-site testing. And finally, the one thing I wanted to highlight is on the policy session, we need to really work with our jurisdictions to make sure we understand any kind of policy barriers that are affecting the ability to do integrated STI HIV screening, as well as provide integrated services. And those valid barriers need to be eliminated. And that includes really making sure that both in STI and HIV clinics that we are promoting and supporting sexual health services and promoting them and normalizing that as much as possible, and ensuring that the service that people get is age appropriate, medically active, and LGBT affirming. So I want to just end here because I'm probably at my 7 minutes, and just say thank you for your attention, and I'll be available for Q's and A's later. Thank you. I guess I'll introduce the next speaker. This is Joe Valentine, my colleague from the STD division. I'm assuming that you're next.
It is me. Good morning again. I want to start out by saying what an absolute privilege it is to be here. I know this is a meeting focusing on HIV, and so when I got the invitation to come and talk about the epidemiology of syphilis, I thought, wow, it's like, I'm always going HIV, and then I always want to nudge somebody and say, and STD, because, HIV is also an STD. And what I want to describe for you in my presentation in my 7 minutes is to sort of help you understand that the burden that our communities face is not just this one bug, but that there are actually other bugs that are also burdensome. And many of the approaches that Dr. McCrae talked about already are the same approaches that we need to look at for STD, but we just sort of forget that there are other STDs. So real quickly, I'm going to describe the disparities, the STI disparities in our country. I'll talk about the specific populations that we are focused on in the Division of STD Prevention, and also then sort of eliminate some of the social determinants of health, which again, will not look very different from those that you experience with HIV. And I should quickly also say that I actually started my career in public health as a street outreach worker in Dallas, Texas, working on HIV prevention. So it's kind of funny now that I have to always nudge people to remind them about the other STDs. And even when I was the syphilis elimination coordinator, when we had the syphilis elimination effort, sort of getting to something that Dr. Warren spoke about in terms of ethics, I began to realize how unethical it was to just talk about syphilis, when in fact there were other STDs going on in communities. And so it's sort of, I began to not believe my own hype, right? So I'm out there pushing syphilis elimination when the US was actually experiencing a pretty serious STD epidemic in general. And so it didn't make much sense to me to just always focus on one bug. So in my world, I'm not bug specific. When I think about sexual health, I think about sexual health and all that it encompasses. And it is not just bugs, it's also how people feel about themselves, how people feel about their partners, how people interrelate with each other. All of these things contribute to sexual health. And so the focus in our office, in the Office of Health Equity and in the Division of STD, is looking at things more comprehensively. So as you can see, the epidemic of STIs in this country are pretty astounding. And these are just the 3 big bacterial STIs that we talk about primarily, which is gonorrhea, syphilis, and chlamydia. So I will emphasize, I'll start with syphilis because that was my charge. I was supposed to talk about the epi of syphilis. So very quickly, I have 3 maps here that describe syphilis, gonorrhea, and chlamydia. And you see that the darker shaded areas of the maps are all in the southeast. And so you can see where the burden is. But what I hope you see here is that where syphilis is, so is gonorrhea, so is chlamydia, so is HIV. We took the 2017 data and began to look at, is there a difference between what happens in urban areas versus rural areas? And actually the burden is higher. You see more disease in urban areas because you have larger populations. But there are some unique challenges to having sexual health issues in rural areas. Primarily, one of them is access to care. I know of many instances where there are clinics that are STD clinics that are only open 2 hours a week. So, you try to imagine somebody trying to go in and get themselves services when the clinic just isn't available. And then you get tested on one day, and you got to come back in another 2 weeks to get your results before you get the treatment. And so when you think about our populations and the challenges they have with transportation and access and getting off work and those kinds of things, how difficult are we making it for people to actually get treatment? And these bacterial STDs, we have a magic bullet. We have treatment that's very effective and we can fix the problem. But when you make it so difficult for people to actually access the services, then it creates more burden for the population. So yes, there is a racial and ethnic disparity in the STI rates. You see very easily by these butterfly charts that where you have most of the disease, it unfortunately tends to be among African Americans, but both for gonorrhea, chlamydia, and for syphilis, the primary disease that I was asked to describe. So, but what you see again is the same patterns repeat themselves over and over again. But you also see that there are disparities for other populations as well. And so if you think about trying to access care in the South, where the distances might not be so astronomical, imagine if you're on a reservation in the Dakotas and you're going 100 miles to get to healthcare services. And so, how do you sort of take care of your health status, whatever your health issues are, trying to get to healthcare when you have to spend all day long just going one way to get there and then get your services, and then maybe somebody says, oh, well, you have to come back in a couple of days to see your test results, and you're facing another 100-mile journey. So I think we have to remember that context is everything. In terms of STIs, there's an age-sex disparity. We have a growing rate of STIs among men who have sex with men, but also primarily among young adults, 15 to 24. And so there are other barriers associated with that in terms of determinants of health, because if you're a kid on your folks' insurance, and now there are going to be these benefit statements that come out that show you were accessing care for your STDs, how you explain that to your mom and dad, where they might not even know you've been sexually active. So these are just examples of context that sort of really impede people. We can give them information, we can provide them with the brochures, you can put out your social media messages, but if the structure of accessing services to get treatment if you need it is so difficult because there are other barriers that we inadvertently created, then in fact they can't actually do anything about it. So when you go back to that notion about the health belief model, you tell a person what's going on, but you have to give them an opportunity to be able to resolve it. But if in fact our systems get in the way of their resolution, what's the point of always telling people bad news with no way to resolve it? So just to point out specifically about the syphilis epidemiology, I wanted to just again reiterate where the burden of syphilis really sits primarily now. It's among men who have sex with men. But it's not limited to that, because we have women who have STIs, and when you have women who have syphilis, you get congenital syphilis. And that too is also rising. And that's infants being born with infectious syphilis, or excuse me, being born with syphilis, which causes many birth defects up and into stillborn deaths. So I'm hurrying. So again, just to reiterate, I've spoken to some of the determinants of health, but you can see again by our primary populations, we're focusing on young adults and adolescents, pregnant women, and men who have sex with men. But what I want you to appreciate is that the determinants of health, really you see them affecting everybody across the board, but there are different ways to respond to that, obviously, and how we might tackle it. But what's most important to remember is that, again, helping somebody know what they need to do to protect their health, to take care of themselves, you have to then create opportunities for them to actually exercise better health choices. So in summary, yes, syphilis is a problem in our country and has had a long-standing history of being a problem, but it is not the only STD. And I'm really excited to have the opportunity to talk about it at an HIV meeting. But I want to remind people that if we have to think about, all of these different diseases as bud-specific, populations don't think like that. Populations think of themselves in total, in a comprehensive way, and we have to approach it in that way. So what I would really recommend is if you're talking about HIV with a group, say an STD, and remind them, and then think about what your strategies are in terms of helping them to resolve their health issues and help reduce their risk for later contracting HIV. If we can actually treat and control the STD epidemic, that may have actually a strong prevention strategy for reducing HIV transmission. But in total, we have to think about people as comprehensive beings, as whole beings, and thinking about their health status in general. And please, please, again, think about the context, because that's always a challenge. We may have great tools and great medications and great ways to reach people, but if in fact the social structures that people are facing to get the treatment that they need, the services that they need, those things become barriers, and that's not on them, that's on us. I'll quit. See who's up.
Well, good morning, everyone. I am Sylvia Adams, and I am the Principal Deputy Assistant Secretary for Health. Or among friends and family, please, they call me the P-dash. Don't ask me why, but yeah, that's what that stands for. Well, first of all, I want to thank the 7/8 Coalition for hosting this important work, because there's so much that's going on in healthcare in the United States. There's a lot going on with epidemics in the United States, but we have not been able to get our hands around HIV. And I think we need to put the focused attention on how do we really strategically get to ending the HIV epidemic. We have goals and milestones that we want to achieve, but I think the bottom line of the solution is that we have to go back to the basics. We have to go back to HIV 101. We have to engage the community and figure out what's going to work for the individual, not necessarily the institution, the county, or the city, or the state. We have to take into context what it's going to take for the individual to be able to access the care that they need. Now, in the 7 minutes that I have this morning, I hope to be able to shed some light on the national plan for ending the HIV epidemic. I work in the Office of the Assistant Secretary for Health at HHS. Prior to that, I was in the Office of the Surgeon General. We did a lot of work on outreach around HIV, a lot of sharing the message. But prior to that, the majority of my career was spent in the Ryan White HIV/AIDS program. And I think a lot of the work that we did at the community level gave us the foundation for understanding how communities interact with the healthcare delivery system, especially in poor and underserved and marginalized communities. And I think that's where I learned a lot of what we're using now to be able to build strategic partnerships and get to the end of the HIV/AIDS epidemic. So first and foremost, as you know, the President announced the initiative 2 years ago at the State of the Union address, where we will eradicate the AIDS epidemic in America by the end of this decade. And that includes a few goals. As I said before, our plan is that we will reduce 75% reduction of new HIV infections in 5 years and 90% in 10 years. And that plan includes a few goals: diagnose, treat, prevent, and respond. This will include a few engagements that we've already began to stand up within the community. The initiative is not just at the HHS level. This is we're coordinating the HHS partners around the federal government within the health sector. So looking at the models that have been developed by CDC, HRSA, FDA, also NIH and IHS. CDC has taken the charge around looking at prevention. PrEP is a big component of this, but it is not the only component. So part of the initiative is to get to understand what's going on around the country. So far, we developed this into phases. So phase 1 jurisdictions, we've been able to visit 88% of those jurisdictions across the HHS enterprise. We've been looking at some of the issues and challenges that have been identified. Access and community, minimizing stigma, coordination of care, looking at talking to CBOs and faith-based communities, as well as identifying the social determinants of health. As was mentioned in the previous presentation, we cannot address the social barriers to get people into care until we understand what they are. And those are at the community level, and they are very, very individually specific. We've also been able to visit some of the phase 1 jurisdictions in coordination with other partners on the ground. So we did, as I've been going out, I've been making sure we include voices from patients. In every visit I go on, I know my team gets a little upset with me. Man, we don't have time. Well, then cancel the rest of the meeting, because if I don't talk to the patient, I don't want to talk to anybody else. That's just me. But we have been meeting with stakeholders at the national level. We've been meeting with stakeholders at the state, local, and regional level as well, to be able to get to an understanding of how we're going to pull this together. So the initiative is ongoing. There's $33 million in FY19 activities were already stood up. As you know, we typically cross fiscal years with funding in the federal government. So the Jumpstart sites, there was $1.5 million of the Minority AIDS Initiative funding, and we do have some representatives here from the Minority AIDS Initiative program. They focus on DeKalb County, Baltimore City, East Baton Rouge, Louisiana, and Cherokee Nation, Oklahoma. Those initiatives are already up and running, and we are also accelerating state and local HIV planning awards. And those have gone to 32 states and local health departments, as well as NASDAD, the National Association of State and Territory AIDS Directors. Now, as I mentioned before, local is what I feel is going to be able to get us the biggest bang for the buck, and as we start to unpack some of the issues, especially in the South. So one of the things that I wanted to do, the ASH asked me to be the PDASH. I said, well, there's a caveat. There's something specifically that I want to work on, and I want to continue to work on HIV. He said, okay, do what you want to do. I said, great. So that was a big mistake. We created these 3 teams to focus on jurisdictions that had the highest burden of HIV. So right now we've been able to get 3 teams in place, regions 4, 6, and 9. Atlanta, Georgia, I have my Atlanta team with me, Commander Dr. Utumaladi, and Lieutenant Kazarian is here with me. They're located in Atlanta. They'll be reaching out to you because you're in the region. In Region 6, I was recently in Dallas, and we did a lot of stakeholder engagement in Dallas with Commander Liz Rivera and Commander Chavez. And in Region 9, we have Commander Sandoval Rosario and Lieutenant Commander Ortiz. We wanted to develop teams that look like the population that they serve. We wanted the teams to be able to understand the culture, the language, as well as the social structures that are limiting access to HIV care and treatment, as well as testing. So we've been looking at across the board, what are the types of toolkits we need to develop for individual communities, and how do we build this set of resources to be able to help us get to the goal of ending the HIV epidemic. And here's what we're looking at: prevention first and then treatment. But there's a whole host of things that we've been able to develop. And I'll go through these pretty quickly because prevention is so important, and I think we've forgotten the importance of prevention at the basic level. HIV 101 should be taught in every community. We know that we're not doing that on a regular basis. When I started my clinical career in we were doing we were seeing a lot lot of my patients come into the trauma units or to the emergency room, and I go transfer someone the following week to the ICU, and I say, oh, what about so-and-so? Ma'am, he died 2 days after you brought him here. We should not be seeing that in this country right now, and that's what we're seeing across the country. So we need to get back to basics and start talking about prevention, talk about linkage to care and retention in care, because we have to get to a place where we're able to use all these prevention and treatment toolkits as we go through this plan to end the HIV epidemic. So moving on, we are Ready, Set, Prep is the initiative that has been launched, and we are very excited about the partnership with Gilead Sciences and providing the prep. It's not perfect, but it's the first step in looking at how you get people who want access to PrEP, access to PrEP. In December 2019, the Ready, Set, Prep program officially was launched and open for enrollment. We have the Chief Operating Officer for the Ending the HIV Epidemic is here with me as well, Mr. Harold Phillips. Harold, and all those questions you want to know about PrEP? Yes, Harold. So, who's eligible for PrEP? And we've gone through a number of challenges in trying to right size who should be eligible, who can get access, and how do you get to it for free. Well, basically, to receive PrEP through the Ready, Set, Prep program, test negative for HIV, have a valid prescription for PrEP, and not have prescription drug coverage. So if you have insurance and don't have drug coverage, or drug coverage doesn't cover PrEP, you still have access to PrEP through this program. For individuals who are enrolled in the program, there is no cost for the medications. On my own time. Our partners for Ready, Set, Prep include CVS Health, Rite Aid, Walgreens, and the Health Mart Pharmacy Network, and that's through McKesson. The partners will donate their services to distribute PrEP at no cost to qualified patients in over 22,000 U.S. pharmacy locations, including D.C., Puerto Rico, and the U.S. Virgin Islands, and through mail order. So if individuals who do not have access to one of these locations or one of the pharmacies in the Health Mart Network, they can receive it through mail order. Partners will also provide patients counseling and will give them information to promote patient adherence through their regimen. Ready, Set, Prep materials are available. You can download the fact sheets. They're available in English and in Spanish. And a lot of work went into making sure they were culturally and linguistically appropriate, not just a direct translation. And people know what I'm talking about. Okay? And we do have subject matter experts on our team who do this on a regular basis, and they've been working with Harold to make sure this is a direct translation, so we know what you mean, but it doesn't mean the same thing in the language. So that level of effort has been expended on that. There are posters in English and in Spanish, as well as the information card, the social media toolkit that's been launched, as well as graphics that can be made available for other social media outlets. Data analysis and visualization system. So this is going to take a little bit more time than we anticipated. There's a plan, then there's a plan, and there's a reality. So what we've learned in phase 1, quarter 2 of fiscal year 2020, the static version of the dashboard that will show each jurisdiction how they're doing as it relates to the level of HIV statistics that are being uploaded into the system. So we're getting, as it says on this, we're getting ahead of it. We're getting ahead of HIV, but we're also trying to make sure we have tools that are developed so each jurisdiction can monitor their success as they progress along the plan. In phase 2, we will have the interactive dashboard provide access to data analysis and decision making, so that if you see there's a spike in certain components of the dashboard, you can make policy decisions, you can make changes in your distribution network, you can make decisions on how you make recommendations to your planning bodies or your policy makers. So in 2020, this is just an overview of the budget, quite comprehensive. As you can see, there have been some, the level of funding that's been committed to this effort is significant. Within our office in OASH, we have maintained the current dollars, which is primarily the Secretary's fund for the Minority AIDS Initiative, and SAMHSA will maintain its 2019 funding level for funding for the ending the HIV epidemic. But CDC has $140 million, HRSA has $70 million for the Ryan White program, and another $50 million for the community health centers to be able to implement PrEP. And this is just an overview of the upcoming funding awards. So those of you who may be interested in either applying for funds or being notified about the applications that you've already submitted, these are the dates that we expect these awards. Early March for all the HRSA programs, the Ryan White program, Part A and Part B, the technical assistance provider, and also the systems coordination provider under VRSA will be announced probably next week. And then the Bureau of Primary Health Care is expecting their awards to go out as early as April. And next, and so the upcoming funding awards for the Ending the Epidemic, Ending the HIV Epidemic at CDC, those are all listed here. We'll make these slides available for you so you can have them for reference. There are several components, components A, B, and C, and those applications will be available on March 25th, 2020, and the proposed award dates are June 2020. Now, looking forward, there are investments, as I said, 10-year project, so you can't fund 10-year projects with 1-year money, right? Glad you can do math. So if you will look at the 2021 budget proposals, you'll see in there the significant increases that have been requested for the department to be able to continue this effort. And you also see the enacted 2020 numbers there. So full transparency, you can see what's been enacted for 2020 and what was requested for the out years. Now, I want to close by saying thank you again for the opportunity to be here. This is important work, and it is wonderful. It is a blessing to be on hallowed ground of Tuskegee University. And next up will be, I think, Rosetta Roberts will be the last speaker on this panel.
I don't have slides, so you guys will just have to look at me. I'm Rosetta Roberts. I'm a native of Tuskegee, and I currently work for Medical Advocacy and Outreach. We are a nonprofit organization who provide HIV primary care to those living with HIV. We've been around for 30 years. We started out as a respite organization providing care to families of those who were living with HIV. During that time, we had no place to provide medical care. There was little being said and little being done to help care for those living with HIV. Our organization started providing transportation vouchers to help those individuals get to UAB because at the time, that was the only institution providing the very new medication called AZT. Fast forward to 30 years later, we are providing care to those living with HIV in about 28 counties here in Alabama. We provide care to about 2,000 patients across that service area. How do we do that? We have a few brick and mortar buildings, one in Montgomery, one in Dothan. We sublease space in Selma, Alabama, and we recently opened up a location in Atmore. We work collaboratively with the Alabama Department of Public Health to provide telemedicine services to counties where there is little or no health care provided. All of the maps that you had a chance to look at today, in addition to syphilis, gonorrhea, you can also cross-section a map that talks about diabetes and hypertension. And those maps also interact with our HIV infection here in the Deep South. We are a Ryan White organization. We do receive some federal dollars, but because we are a Ryan White organization, we are very limited in what we can do outside of HIV care and even with PrEP. We do have a PrEP clinic that we offer Mondays and Wednesdays in our office, but is that enough? Not really. Because of the stigma that's associated with HIV, here in the South, we are faced with challenges on a daily basis. It's hard to get our patients to adhere to treatment. It's hard to get them to come in. Why? Because the person sitting at the front desk may be also the person that goes to church with them, that they see in the community, and they're just not ready to disclose. So we have a hard time with trying to keep our patients engaged and active in their care. Some of the things that we've done to be able to combat those issues, we have extended our clinic hours. We offer a night clinic. Again, we have our telemedicine sites, and we have made the initiative to hire folk that look like our patients that we serve. We use our funding to the best of our ability, and we've been very fortunate to secure staff that are committed to the cause and fight for HIV. I'm very delighted to be here, and I'm excited to take your questions, but I'd also like to thank the staff of MAO for coming out and supporting supporting in initiatives like this, because again, Tuskegee is a very prominent face in the community, and we look forward to working with you to help end the epidemic. Dr. Barbara Owens, who's also my mentor, is here with us today. She is our Assistant Medical Director and has been a prominent force in the community to help us end the epidemic. One of the things that she's constantly fighting with her colleagues about, our African American providers in this area, is how do they get testing? How do you get testing and bypass the laws or rules that's taxed to insurance? You can get tested for diabetes and high cholesterol and all those things with very minimal copay expectancy. But a lot of times that's not the case in getting tested for HIV with your primary health care. So we're trying to work with them on the proper diagnosis codes so that we can include that in routine screening. I applaud the efforts of the CDC in trying to streamline the way we think about HIV. It's important. CDC tells us anybody from the age of 17 to 77 should be tested at least one time for HIV. The more as healthcare providers as we can destigmatize the language associated with HIV, the closer we will be to ending the epidemic. It's just real important that we just all talk about sexual health care in a positive realm so that we can get the testing done that needs to be done, get people into treatment, because we know what happens when you get into treatment. You decrease the viral load and the CD4 goes up, their immune system becomes a lot better, and you live long, healthy lives. But until we release the stigma that's associated with HIV, we will never get to end the epidemic. Again, thank you for this opportunity to just offer our services at MAO, and we look forward to working with each of you in the community real soon. Thanks.
We got about 10 minutes to do about 20 minutes worth of engagement. So I'm going to first thank you for being here, and also apologize. I got caught up with being at TU. It happens all the time. And if you leave here with understanding the institution, the other stuff is processed. So I hope you get a good sense of the institution. Dr. Aquarius, what would you talk a lot about the statistics, the epidemiology. How can CDC engage in a way that you think is meaningful for the routine?
Yeah, thank you. So, CDC has limited capacity, but one way to engage is really by having us, engaging with the health departments that we directly fund. Because we are a federal agency, it's challenging for us to just go directly into the state and into a community to do work. But we can, working through health departments and through community-based organizations, to invite us to participate, get engaged. As part of the end of the HIV epidemic, we have worked collaboratively with HRSA and other partners to develop sort of some guide on how to really do effective community engagement. And we certainly are working with our health department to ensure that that happens.
Thank you. Ms. Valentine, in terms of full disclosure, is a project officer for the National Center for Bioethics. And she's our liaison with CDC. That we've had a very engaging and productive time over the last several years. Ms. Valentine, how do you think you can help to guide the National Center to engage with this activity?
I think what I earlier said, that if we begin to think about these issues in a more comprehensive fashion, I think when you talk about public health ethics and an ethical approach to working with populations who've been underserved, who experienced racism and discrimination, the lessons learned from the Syphilis study, for instance, can help us to actually understand and respect why people have a healthy suspicion of the government coming to help them, given our unfortunate past. But the Bioethics Center in particular can help to bring people together in a conversation, not just about a bug specific, one bug, one disease, but to talk about health in general, but also then to embrace these issues of stigma specifically. I remember early on in one of the public health ethics intensive week that we had here at Tuskegee, we actually talked about sexual health, and we provided education to the junior high kids and to the college kids and talked about how to take care of yourself and what is a healthy relationship, and what, we went beyond just AIDS is caused by a virus and, syphilis is a spirochete. We went into really how to protect yourself and how to live in a way that promotes your own health, both mentally, emotionally, and physically. And so I think the Bioethics Center can be a leader in that regard, but then so can the university. I think creating an environment where it's safe to talk about these issues and people can feel like it's not stigmatizing to raise questions and concerns, letting people talk about it in a way that doesn't shame them, but actually allows them to get information. I think that is one really critical way.
Thank you. We talk about trust and mistrust, and we've just done some work about how do you build trust. And you do that by demonstrating trustworthiness, and that takes time. And that's a paradigm shift that I hope you will consider. Don't ask me to trust you, prove yourself trustworthy. And I can say in the public domain, Ms. Valentine has done that. I was at CDC for many years, and I left not trusting. Straight up. Over time, I began to trust Ms. Valentine. And so she carries the battle, because if I took it there, I'd lose. So we worked together, and we built a very trustworthy relationship, and I'm very proud of that. Admiral, we've reframed the Tuskegee Syphilis Study to its proper and correct name, U.S. Public Health Service Syphilis Study at Tuskegee. You in the U.S. Public Health Service, and you wear proudly your uniform. How do you engage the African American community with that legacy?
Well, I think the first thing is we need to back up and look at what's the United States Public Health Service versus what's the Commission Corps. So I am a part of the Public Health Service, but I'm in the Commission Corps. Now, the Public Health Service includes the agencies that are under the Public Health Service, which are HRSA, CDC, SAMHSA, FDA, NIH. So those agencies are part of the Public Health Service, and then those individual agencies fund activities that then become a part of the work that's done in the community. When I go out, they see the uniform, and they know I'm in the Commission Corps. Usually they think I'm a pilot or in the Navy. And then when I right-size that scenario. But as a public health service, what I do is, just what you said, on an individual basis, I have to engage people with authenticity and with the sense that I'm a healthcare provider, I'm a nurse, and I engage with people. And I show up, and I continue to show up, and to build that relationship. Many years in HRSA, we went into communities whereby they did not trust the government, didn't trust healthcare professionals, and didn't want to talk about HIV. But you keep going, knocking on the door, and just waiting for people to open up and meet them where they are. I think that's what we have to do. And with the Syphilis Study, as a part of that organization, the United States Public Health Service, as a part of HHS, we have to own it. We have to own it and acknowledge it, and then unpack what was a part of that study, and use it to better the movement and as it relates to bioethics, but more importantly, teach people what not to do. What we learned from that study, that was not the appropriate way to deal with people on a human level, but also the wrong way to conduct research.
Very, very good and very honest. We got to own it. We say the U.S. Public Health Service Central Study at Tuskegee. We're not saying that Tuskegee didn't have some kind of engagement. But we got to understand that. So we all have to own our own responsibility to resolve the overall issue. And the overall issue, from my perspective, Ms. Roberts, is the challenges with racism and mistrust. And that's a big one. But how do you approach that in the work that you do?
Great question. Challenges and mistrust that we deal with. Of course, HIV comes with its own set of stigma. Its own set of stigma. Can you hear me? HIV comes with its own set of stigma. And how do we combat that? By being available, by being present, by being honest, listening to our clients that we serve, giving them options, not trying to force them to do things our way, listening, just being present, being in their moment, providing them with the health education that they need so that they can make those decisions on their own. The last thing you want to do is force someone to do your way of medicine or to force them to take medication that they're not ready to take. So providing them with the education that they need so that they can make a decision about their own health care. That's kind of what we do.
Well, we want to close with a message. You know, I was taught that you can talk a lot, but you want your audience to have one take-home message. We do that with our class. We call it SOC. I learned that language at CDC, in fact. So there's one thing, one take-home message you'd like this audience to leave here with, from what you said or what you've heard. What would that message be?
Release the stigma within yourself.
Okay. I hope y'all heard that. Yes, ma'am. Take-home message.
One take-home message is that we all have to work together to end the HIV epidemic.
She took my message, but I would also say that you need to be comfortable with who you are before you can be comfortable with the people around you. So I think being humble and willing to listen and hear what others have to say and then process that is really critical if we're going to make a difference in this epidemic.
I would say respect the experiences of your client populations and your communities and think comprehensively about health.
We've got a group of people here who have something to say.
Start by, like every other health concern. I think Ms. Valentine, you spoke directly to that during your speech about STDs don't happen in a public health vacuum. What are some of the suggestions or ideas that we can work with in a place like Alabama? I think the whole reason that we are in Tuskegee beyond the Tuskegee Experiment is that the reality of the lived experiences of people here are so different than some of, say, our colleagues who are working and living in New York City.
You get the question?
I can start. That's a really good question. There's several things that I think we can do, and I can promise that we'll be successful. But one of the things that we're doing is, all of the jurisdictions have submitted plans. Some of those plans are better than others. But one of the things we asked them to identify were policy and political barriers that would prevent them from accomplishing the goals of the initiative. Some of them are very honest, and we're collating all that information. It's going to be shared with leadership. And our goal is to prioritize those and say, these are the things that leadership has to work on if we're going to be successful. The other thing that I think Harold and his office is doing, and they're doing very well, is making sure we're getting linked to the other players that need to be a part of the picture, like Center for Medicaid Services, ensuring that they are part of the process. Housing is at the table now. And then thinking creatively about how we make sure those linkages occur and the community knows how those linkages can occur, because it's amazing when you go to a health department. Many of them have never talked to the folks in housing. They may know what hospital is, but they don't know that there's a huge housing program that is available for people who are not living with executive. So making those connections are going to be critical. But the challenges, the big things that you mentioned, some of the political and policies at state and local level that will require political will and political policy changes are really things that we're asking our leadership to help us with. And I'm not optimistic that some of them will change, but I think we have this start.
Thank you. Ma'am?
Good morning.
Yes.
Good morning. Admiral Trent Adams, here's, you talked so eloquently about us going back to the earlier days of prevention. I'm adding to that conversation that, especially in the South, and our experience, that folks typically don't show up till they're sick. You spoke of it in your presentation. Can you enlighten us on the decision that was made on the PrEP initiative, where even organizations such as ours who prescribe PrEP, who have clinics and or have integrated STD and HIV services, were left out of the formulary, where the funding went primarily to federally qualified health centers, which certainly it should be part of it, but we were left, it seems like we were left out of the loop. And so we have clients that fit the description of what you provided, but we're unable to access that resource and build their capacity to prevent HIV infection.
Thank you, Dr. Gaddis. I think one of the things that I also mentioned, that the plan is not perfect, and I appreciate your feedback. We know that there are some people who are some organizations and individual jurisdictions that were left out, and we know that this is going to be an iterative process. I'm glad Harold's here because that's something that he can take back as well. But here's a challenge. We were working on the framework with how do we get funding to those organizations most expeditiously that are already serving, and that we have a funding stream aligned to get to them. You can't wait for a whole another cycle because that's an 18-month process before we start. You gotta start somewhere. So the first thing was, who's currently federally funded? We have a direct line to providing comprehensive services under specific categories where we have a means of being able to fund them with a supplemental or with other mechanisms that will get this money out the door quickly.
I would just ask that if it's directly funded by CDC, and we have a partnership already established, that we might be considered.
Absolutely.
Because we already have a relationship.
That's a very good point. Thank you.
We have little time and 3 more questions. So let's go through those quickly, please.
Yes, thank you also very much for your presentation. Max working with the Black AIDS Institute. One of the things that was brought up around the pieces that are going out through the health departments, we have had an extreme problem around getting those plans back to community, back to organizations that are doing the work, and repeatedly asking them, where are the plans? How can we see the plans? And what are ways in which the federal government is working to make sure that those plans are actually transparent and accountable to community? And also, when we are looking into when there are community engagement events or when they're supposed to be engaging folks, we are, many times the community is let to know about those very last minute and not given actually time to prepare, get folks together, and even the timing of some of those events is just very ill-advised and not actually helpful for community to get there. What are ways in which the federal government is helping to make sure that those are out there, community can have that, or even having a list of where those community engagement events will be so our organizations can help get folks there?
I can start with, I think you know that the timeline for getting these draft plans in was very compressed, so the planning process clearly was not perfect, and different jurisdictions were in different places. So we do have draft plans from all of the jurisdictions, and as I mentioned before, I would say a significant number of them are not where they need to be, but that's not, the planning is an iterative process. And what a number of the plans do highlight is that there are a number of organizations that they have not engaged with, and there are organizations that they've engaged with, but they know that engagement was not optimal. And they have outlined some of the things that they want to do. So as we're reviewing the plans, and I say we collectively, is the CDC, HRSA, and people from the Office of Infectious Disease Policy, those plans are being reviewed, and we're planning to by the end of March, provide feedback to the jurisdictions, and they will continue to develop and enhance those plans. And we're specifically highlighting certain things that are missing within the plan, especially some of the partners that should be there. And I want to say, specifically related to historically black colleges and university, we were deliberate in making sure in jurisdictions where there were HBCUs that they were included, that we want to make sure they are being included in the planning process. This is an opportunity to really get to young African Americans, both men who have sexual men and others, who are potentially at risk and can benefit from prevention interventions.
Last two quick questions, please.
Thank you. I too have been inspired by being here at Tuskegee. I'm Jesse Mylan from AIDS United, and a couple of years ago I had the amazing experience to act and sing the role of Booker T. Washington in a production of Ragtime, so I'm going to try to channel him as he spoke to presidents. He spoke to presidents, and I think we have to put this conversation in a political context, and Eugene, I appreciate that he said it's a policy context, but it's also a political context. It's about mistrust. And I'm going to preface it also by saying how much our community appreciates the roles that you play inside of this administration. We know it's hard, and you are our heroes for taking on and continuing to do the work on our behalf. So thank
you. About 10 minutes to finish this out.
But the question really is, how for our community do we balance the mistrust that so many of us feel around some of the policies of this administration that impact HIV, such as the religious conscience rule that will make discrimination against LGBT people possible, the Medicaid block grants that's going to make it harder for our people to get into care and stay into care, and even a massive cut to HOPWA, which is truly going to impact our people. How do we balance that, which leads to mistrust, with the $450 million new dollars for the Ending the Epidemic plan? Where is the balance, or is it our job to make sure that it is rebalanced?
Thank you.
Jesse never gives you easy questions.
Yeah, right.
Jesse, I think it is more the latter. I do think that internally there are limitations on what we can and can't push. We've helped shape and frame the policy. I think those of us who've been in HIV in the department for a long time have been able to convince some people that option A is not necessarily the best option. You need to look at B, and B may not work in this community. And I think collectively, Harold, you can speak to this better than I can, there have been some significant changes in scope and focus because of the input that we have provided. That may not be translated across the entire department as relates to policy per se, but I think as we start to see the results of what we're doing at EHE, we will definitely be able to use the data to make changes in policy as well as the approach. I am concerned about some of the dynamics of what we're doing in EHE and how it may or may not go over so well because of where we are with trust and belief in what it is that can be achieved because of other limitations outside of health. There are so many other social determinants of health, with education, economic equity, and other challenges that feed into health mistrust because, if you're not health literate, you're not going to access the healthcare delivery system. So I think overall we need to have incremental change is what we usually do in the United States. That's going to be a part of the same dynamic for EHE. We're not going to be able to change this overnight. The other thing is, yes, you guys need to be involved. You need to push us like you always have. We used to say at HRSA, a good day is when we come to work and act up in AIDS action. It's not stretched out across Fisher's Lane. That's the kind of pressure it took, and you know this. That's what it took to be able to get Ryan White pushed, to speed up the drug approval process, to change the framework for how we provided care, how we approved certain lines of efforts around building the Ryan White program. So yes, it's going to take external pressure as well as an insight from the inside, but using data and science to drive decision making.
Last question, sir.
Yeah, good evening, good afternoon, everybody. I had a lot of questions about the epidemic and everything, but since I'm the last one, I'd like to give an example of why this gentleman would say that this is hollow ground. Because I too was a student here back in the 70s when they called this Tuskegee Institute. My math teacher told me about going to college, and I had this conversation where I didn't want to do it. She said, well, just go down there and tell them that I sent you. So I went all over the administration building, telling everybody that my mama brought me down there first of all with one suitcase. And I went all through these administration buildings telling everybody that Miss Thompson sent me. Nobody didn't know who Miss Thompson was. And my mama was gone. But by the end of the day, I was given a 4-year scholarship and a job and a room in the barracks in the dormitory. I want to say thank you, Tuskegee.
Well, as our panel takes a picture, let's give them another round of applause. So that we can move things along rather quickly. I want to tell you we're all set up for lunch. So we have 2 serving stations. One, if you'll go to this exit door,